everybody. Nice to see your smiling faces. We hope you're all doing well, particularly the folk from Philippines, where I know there's been some very difficult weather, and we hope everybody's managed to get through that okay.
Yeah, good morning, everyone.
Morning, Jennifer.
Good morning, ma'am.
Okay, just wait for a few more minutes as people come online. It looks like you've grown wings there, Rina.
Morning.
You're an angel.
Yes, looks like this. How are you doing, Professor Chris?
Oh, very well, thank you. And it's always a delight to see everybody show up. So we're just talking about how engaged you all are as a group, and people looking at the resources and asking some good questions. So we'll tackle some of those. Okay, I think we're
Yeah, we can start.
We
Chris.
can start.
I'll just email those
Okay.
who are not here.
Well, kia ora koutou, welcome, welcome, tēnā koutou, tēnā koutou, tēnā koutou katoa. We're going to begin our session together today with a karakia, as is our practice. And I'm going to read a karakia timatanga, which goes like this. E te kaihanga o te ao whakatonguia, mai te maramatanga, e ārahi, ia mātou whakaaro, ia mātou mahi. Kia u, ki te tika, kia u, ki te pono, kia rere tonu te Māori, ki ngā whaka ti pūranga āmene. Creator of the world, plant understanding within us, guide our thoughts and our work, help us to stay anchored or focused in what is right and true, and let our energy and intention flow forward to the future generations. Wow. So we're just moving out of all the other things we've been busy with so far today, and we're going to work together as a group, learning some new material, maybe covering some familiar material, but hopefully gaining some new insights and some approaches to thinking about how we go about our work in public health, in leadership roles, or in growing into leadership roles and developing an understanding of the role of public health managers and leaders in this space. So today's session is a bit of a combo session, and we're going to start with a bit of feedback on homework from Dr. Monica, and then we're going to have a break after, then we're going to go straight into Dr. PP's session on intersectoral healthy public policy, and then that's health in all policies, or healthy public policy, and then we'll have a break for about 20 minutes, and then we'll start to focus in on disease prevention, and we're going to have 2 sessions on disease prevention. I'm taking one tomorrow afternoon, which is focusing around immunization, but Monica will give us some frameworks to use to apply. And if you remember the definition that we started with right at the beginning about what is public health, it's the art and science of promoting health, preventing disease, promoting health, prolonging life through the organized efforts of society. So we've got this twofold element of health promotion and disease prevention. So we've done quite a bit, and we'll cover some more health promotion as the course goes through, which has a strong focus on wellness, not just on disease, but we also have to have the yin and the yang, right? So the yin is health promotion and the yang is the disease prevention. And so we'll be talking about that today as well. But without further ado, I'm going to hand over to Monica, and she will just provide you with a bit of feedback on some of that homework, which many of you engaged with. So thanks, Monica.
Yeah, thank you, Chris. Kia ora, everyone. So I just want to make a quick feedback for your homework. And before that, I thank you for your engagement on our last meeting. It was a nice session, and maybe I need to remind you that we talk about communication, and I gave some example from New Zealand and also from Southeast Asia, and Put also explain how we can create public health communication, and we did some small group work, and also we gave you some homework, and we saw, I think, about 4 or 5 participants already posted their homework, and Put and I had written our comments related to your homework. And I see, I think all of the homework you are using the AVVB set formula that Put has taught you on the last session. And I think you did very well. And it's nice to see a lot of examples. And I think from your examples on the discussion, all of the poster, they really put more focus on the audience, and I think that also one of the most important thing. And then I also see that the example use high quality picture or well designed picture. So I think we talk about how public health communication use interdisciplinary fields, and your homeworks show that, yeah, it's not only people who work in health related sector, but also people who work on education or on design or on literature. They can also help to make a public health communication. Yeah, I think that's all my feedback, but we only have 5 people who posted in the discussion board. So I still encourage you to post. I think mostly who post are from Indonesia. I also want to see some other example of poster from other countries. So I know you are busy with your work, so it's okay if you take more time to find the poster and you need more time to analyze. But if you already have, just post it, and I will give comment, or Put will give comment related to your homework. Okay, that's all from me. Thank you. I hand
Thanks.
to okay,
Yeah,
please.
I'll just interject briefly just to say I've posted a comment in Canvas in the announcements. So if you click on announcements along the side, you'll see a comment which has got some links, because one of you asked about how do we share our learnings, our knowledge, etc. in New Zealand, so that we can pick up new ideas and try new things out from what other people have been doing. And I was trying to think about the various things that I know about, which isn't completely comprehensive, but I've put some URLs there for you to go and explore. So some of it is material that's covered by the Ministry of Health, and they've got a lot of really good resources. So I get an email from the Ministry of Health library every month, and it's got a whole lot of resources under different headings like communicable disease, non-communicable diseases, tobacco control, other things that I'm interested in. And they post the links to papers, articles, or project reports that have been done in New Zealand and overseas. And I find that really helpful. And I also subscribe to some of the email news that comes through various organizations within the ministry, within government, our what's called Health NZ, which is our provider of the New Zealand National Health Service, and also some organisations that are based with the community that deliver services under contract from our Ministry of Health. And they provide very detailed accounts of different projects and programs that are being run and their evaluations and so forth. So I pick up a lot from that. And there's a, for example, in the Tobacco Control Service, there's a monthly what we call a meeting online, just like this, but you have probably about 200 people from all over the country. And yesterday, for example, I gave a little presentation about some results from a research project, and then we got feedback from all the people about what they could learn from that and how they could translate that into their practice in their part of the country. So there's all sorts of platforms. There's no one-stop shop, but probably the links that I sent you would be a good place to start if you're interested. So we haven't got it 100%. Some of your countries may have a much better approach that's more comprehensive, but the ones that I link into in New Zealand are extremely helpful, and they might give you some tips. Anyway, so I'll leave that over to you to explore in your own time, but handing over to PP now. Thanks, PP.
Thanks, Chris and Monica. I will need to start sharing my screen. Yes, so today's session is health in all policy. And before I start today's session, I also would like to discuss about the homework that we discussed, like, like I think they do's homework, which is let's try finding some data. So until this morning, I saw 11 people posted your exercise and your answer. And I'm quite impressed with your answer because like you chose different types of indicator and then also talk about the sources, why this indicator is important, what the data is telling us. Like, also you choose like different types of indicator for different diseases, like which gives a kind of a good picture of the situation of the public health as well as for the disease control. So thank you very much for sharing all your great work, and it's very interesting. And since we don't have enough time, I'm trying to respond to each and every one of the exercises, and then I reply via comments on the canvas. And yeah, I just would like to reflect that I'm very impressed with your work, and some of them are quite comprehensive, and some of them also, a lot of them, I think all of them, you talk about the data as well as you reflect the situation, how this data is telling us what's the story behind. So yeah, congratulations to all of you. Great work. So with that, I would like to start today's session. Today's session we will have
sorry,
like
PP.
Sorry,
some.
PP,
Yeah.
you are in presenter view.
Oh, okay, sure. Is it okay now?
No,
No.
please go to presentation mode. Like we could see all your slides at the side.
I will reshare again. It's okay. Is it better?
Perfect.
Yep.
Okay, thank you very much. Yeah, so today we are going to talk about health in all policy or healthy public policy. So we are coming back to day one, which Chris discussed about Ottawa Charter, which was established in 1986 and stay very relevant until today. So if we look at the different components, we can see that one of the most fundamental thing is within the healthy public health public policy, which I will discuss about it today. After the Ottawa Charter, we have Adelaide recommendation, which was established in 1988. So it is characterized by an explicit concern for the health and equity in all areas of policy and by an accountability for health impact. That means that health is not just about Ministry of Health or health sector, but also by everyone. So I think we touched on this a little bit during our discussion, how, for example, in the example of NCD, how multi-sectoral policies are important because health is actually getting the impact of all other policy, and then rather than our sector alone will not be able to to promote the health promotion approach for entire population. So I think we've already started getting this concept, and we already started discussing about this concept. And the main aim of the healthy public policy is to create a supportive environment to enable people to lead healthy lives, not just the disease prevention, from all the aspects of their lives. And then such a policy makes health choices possible or easier for citizens. And it makes social and physical environment health enhancing. We discussed about one example about like having Coca-Cola machine while we in hospital why we are talking about like like healthy lifestyle. So we talk about like how this and environments are important for us to make healthy choices. That is one of the policy, but this is the main concept behind it. And so before we go further, I'd like to give you one example about Healthy Auckland Together. So this is initiative from Auckland, which is one of the big city of the New Zealand. And then so we acknowledge the obesity problem is a result of normal response by normal people to abnormal environment. That means everybody's like to be healthy and we want to be healthy, but at the same time, our environment are not creating the healthy lifestyle and enhancement environment. We have no choice. So this way we try to work together for the to make it healthier for Auckland. So we need to take care of the food, urban, school, work, transport environment so that we all will contribute to Auckland's health. So all the we have 26 organizations, local government, which is Maori tribal groups, and also NGOs, university, consumer interest group. We come together with this project, which I will present through the YouTube video. Yeah, this is about healthy. I hope you can hear me okay. This is YouTube video, which is explaining about this Healthy Auckland Together project. Second.
Tamaki Makaurau, Auckland, New Zealand's biggest city, with more than 1.6 million people. But have you ever wondered just how healthy we are as a city? Healthy Auckland Together has just released its 4th annual report into the health of Aucklanders. It's called the Healthy Auckland Scorecard. The report looks at how Auckland adults and children are doing when it comes to obesity, nutrition and physical activity. Dr. Michael Hale talks about the report's findings and what they mean.
I'm Dr. Michael Hale. I'm a public health doctor for Auckland Regional Public Health Service, a member of Healthy Auckland Together.
We've seen the rate of adult obesity triple in the course of a generation. And concerningly, this is deep in children too. The rate of children's obesity is now 15%. Affecting all of us right across the lifespan, this points to something in our environment that's affecting us all and causing us to put on weight. Yeah, well, where you live is key. People living in poorer suburbs have 2.7 times the rate of obesity than others. For children, it's the same. 26% of children who are in the poorer areas, as compared to 3% in the richer areas, are obese. And this travels into other health issues as well. When we look at the rate of dental decay in children, those in the most deprived areas have 10 times the rates of those children in the wealthy areas. So we can really see an environmental influence in that as well. Obesity is one of the leading causes of ill health in New Zealand. It leads to cardiovascular disease, depression, some cancers. Obesity is really important from a societal cost perspective. We know that to the healthcare and society, it's in the vicinity of $800 million a year what we spend on obesity. Yeah, it's particularly important for children. We know that both weight gain is set early on in life and the trajectory continues. And we also know that tastes and preferences are set at that time too. This is why food and drink companies deliberately target our children to try and set those tastes for unhealthy products that they'll be then hooked on for the rest of their lives. We know, for example, that the average child sees 27 ads for unhealthy food in a given day. What we eat is really determined by our income, what's around us in our neighbourhoods, what's marketed to us and our children. And too often it's sugary, low nutrition choices that are presented to us at every turn. Well, there's work to do here too. less than half of adult Aucklanders are getting the required amount of physical activity per week. And we're missing a lot of opportunities to get good exercise in. We know that kids taking active means to get to school, whether that's biking or scootering, that's decreased across the Auckland region. And adult Aucklanders spend over 6 working weeks a year in a car. That's plenty of opportunity that could have been used to be physically active if other options were available. Well, we've seen a good start in children or preschool children's levels of obesity. And particularly pleasing is how there's been a reduction in the gaps between ethnicities. Pacific children over the last 5 years have seen obesity rates fall by 11%, and over the same time, Māori children have seen their rates fall by 9%. And so that's seen the levels of obesity in the population come to a more even playing field. But there's a long way to go, and what we need to see is the current rate of Pacific obesity at 35% and Māori rates at 22% continue to fall at that speed and faster if we're to see true health equity. Yes, we have joined a number of other countries that have seen the preschool obesity rate fall, and that's very encouraging. But what is it we haven't nailed yet is that once the children get into the school environment and beyond, we're not seeing that obesity decline maintained, but we're seeing it join the adult rates and slowly increasing. So something is happening outside of that preschool environment, that young environment. It's pointing to the fact that parents have less control and that children are more vulnerable to the market forces, to the overarching system and environment that they face. The older they get, the more at the whims of that environment they are. So despite all this evidence that children are being targeted and that everywhere we turn there's an abundance of unhealthy food provision and marketing, there's no law that protects children from junk food marketing. It's very much like we've got our hands off and the industry has their hands on our children.
We need to significantly improve the food environment for all of us, but especially for our children. We could do that by introducing government regulation of junk food advertising. Government regulation could close the current loopholes, including ensuring there are regulations on television junk food advertising during children's peak viewing times, not just during children's programming. Unhealthy food and drink sponsorships of children's sports and clubs becomes a thing of the past. Packaging, promotions and giveaways can no longer sit outside the regulations, and meaningful financial penalties or other robust sanctions exist for those that flout the law.
Well, I think we need to look at those places we eat food in our day-to-day lives and what are the default options available there. So this is where we work, this is at schools, this is sports, clubs and events. We need to have good, healthy options just readily available so that those treat options are found far less and that they actually become treats again.
Head on over to the Healthy Auckland Together website, where you can download the full Healthy Auckland scorecard and check out some of the work Healthy Auckland Together partners are already doing to help make Auckland a healthier city.
Okay, this was one of the examples from New Zealand, like Healthy Organ Together, like initiative. I think you will see that how much of this aggregated data was used, like in terms of worthiness, as well as the ethnicity, and as well as the like locations. So we look at the data, like even for the Auckland data, from the disaggregated point of view, and see the problem, and then start to tackle the problem. So if we look at the recommendation, I think it's not really health sector, it's from other sector, like either food environment or advertisements or like regulation. So these are like out of health sector, but still all of them cause a lot of all of them are contributing to obesity, which would cause a lot to the health sector and society. So that's why it's important to promote the healthy public policy in all the sector, not just focusing on health. So that was one of the examples from New Zealand. And if you are interested, please feel free to Google it. We also share the links in the study material on the canvas too. And here is another example from the UK. When it comes to roads or road improvement, who should be involved in decision about our street, roads, or motorway? Yes, it's Ministry of Transport, and why not the Ministry of Health? And then who else should have a voice? Please feel free to type it in the chat. Who else should have a voice in terms of roads, streets, or motorway? We may not have enough time for me to pause and then give you to have a talk, but please feel free to type it in the chat. We can check the chat later. So this is the initiative from the UK, which is the healthystreets.com. So they created the 10 evidence-based indicator for healthy streets used in London in UK. So people can go and then go to the app and then they can just score this street. Healthy streets, every district, whatever they feel, they can do their scoring. Everyone feels welcome, easy to cross, shake and shut up, places to stop and rest, not too noisy. So everything they can just give their comments on their rating on the app. So that means every decision we make about our built environment, however small, is an opportunity to deliver better places for people to live in, and thereby improve their health. So everyone can contribute and then provide their feedback for our environment to contribute to the healthy public policy. Here is transport policy. So citizens can follow their progress and make informed decisions. So if you can see from the map that citizens are doing and then scoring, providing their score. Some of the streets are very red, some of the streets are green. So these are citizens are informed and involved along the process, and keep local government and businesses accountable for making environment healthier. By looking at this, if this street is dark red all the time, what's wrong with it? What indicator is not making well? So that means that local government and businesses are accountable in this very transparent mechanism by their consumer, as well as all the citizens who are using, all the people who are using the street. So this is one of the initiatives from London, and I share the link with you also. You can also have a look at the website. Here is another video about health in all policy, or healthy public policy. So better policy means better health. I will just play it now.
What's most important to you in life? Many of us would say our loved ones, including family, friends, and pets, our paid and volunteer work, our faith, sports, hobbies, and social activities all help make our lives more meaningful and fun. But in order to live our best lives, health is a resource for optimum everyday living. We all know that we should eat healthy foods, smoke and drink less, and get exercise. But how easy is it to eat healthy foods when there's no grocery store nearby, and the cost of these foods is more than unhealthy foods? Or how easy is it to exercise outdoors when there are no parks nearby? How can we focus on making changes like smoking less when our main concern is paying rent? What if we were focusing on the wrong things to get and keep healthy? Because what matters more are the conditions in which we are born, grow, work, live, and age. These things are known as the social determinants of health. Things like early childhood development, education, employment, working conditions, job security, income, housing, food insecurity, social support and community belonging, and physical environments have a tremendous impact on our day-to-day lives and subsequently on our health. Having access to good healthcare is important too, but research indicates that healthcare is less important than the other social determinants of health in influencing our health, particularly in preventing us from getting sick in the first place. Why is it then that when we look at healthcare spending and ways to improve population health, we see there's a large focus on hospitals and medical treatment? What if we considered focusing on the areas of our lives that are most influential in determining our health and well-being over time? We would then need to consider health not just in the healthcare sector, but in all sectors. What if our decision makers, like the government, consider the impacts on population health in the policies and decision of all sectors? This is health in all policies. Health in all policies is an approach to public policy that involves various government sectors working together to make sure policies and decisions from all sectors are considered for their impacts on health. It creates healthier environments for all people, so they actually have the opportunity to make healthy choices. Health in all policies is being used around the world, with documented positive outcomes. What about us in Ontario? We too can implement policies that ensure health is addressed in the sectors where decisions and policies have a large impact on our health. But to do so, we need to get informed about the determinants of health and available solutions. So please share this video. Learn more about this topic. Feel free to comment with questions and suggestions. And thanks for watching.
Sorry. Yeah.
PP,
Now
I
you
think
can.
you're on yeah. Can you move to presentation mode? I could see your
Oh, okay.
notes.
I see. Sorry about that. Can you see the screen now? Or?
Yeah, we could see the notes. It's in the notes.
Oh,
View.
okay. I will try to reshare again. Sorry about that. It's with the video. Yeah. Yeah. Is it okay now?
Yeah, could you, is it, I'm not sure if this is your actual slide. How will this policy impact health? Like the
Yeah,
part.
yeah. That's
Okay,
true.
yep,
Yeah.
we can see it.
Thank you. Thank you.
Well
Sorry
done.
about that. So as you can see that there were a lot of key passages, and then at the end, we all need to think about, for every public policy, we need to think how will this policy impact health, and then how will these health impact be distributed, meaning that this is talking about the health equities, because we always need to look at, like, sometimes some people will get benefit from this policy, but not the other people. So we need to make sure that the impact will be equitably distributed. So that's the essence of healthy public policy, and linking with all the all the foundation of the discussion that we did from the day one. So this is the head in all policy statement from Adelaide in 2010. So this emphasized the government objectives are best achieved when all the sector include health and well-being as a key component of policy development. So that means health is not just the healthcare unit or healthcare system, because like we said that when they walk into the clinic or the hospital, the cost is already high. Our main public health promotion intention is to make sure that people will not come to the clinic or will not be sick, but to promote their health so that they can enjoy their healthy lifestyle. So the health sector will not be able to do it alone, and all the sector have to include health and well-being as a key component of policy development. So this is the key from the health in all policy or healthy public policy. So another one is from Helsinki, is in 2010. So health in all policy means that we need to emphasize on the consequence of public policy on health system, determinants of health and well-being. So like, for example, if we allow all the let's go back to the healthy Auckland example. So we had all the in the food environments, there are unhealthy food promotion around children. Of course, the the other government or the whatever the ministry that is looking at that is maybe the Ministry of Trade. So they may allow the advertisements of the unhealthy drinks or unhealthy food around children, but they may have some tax, but at the same time, the cost is really high. So that means that we need to think about the consequence for every policy. We need to think about the consequence of those public policy on health system, the dominance of health and well-being. So this is the essence of health in all policy. And I'm sure that there are many other sectors are operating in their way, but we as public health professional, we need to ensure that health in all policy is implemented in our countries. And this is from the Helsinki statement too. And it includes the call for action to the government. And then at the end, if you look at it, we need to adopt transparent audit and accountability mechanism. So that means that health and equity impacts that build trust across government and between government and their people should be there. For example, one sector, they just adopt this policy without thinking the head in all policy. That means people will get sick and then people will not have access to healthy food. That means there are lack of health and equity impact. But that's why to avoid those kind of things, we have to ensure that there is transparent audit and accountability mechanism in all the government sector. And establish conflict of interest measure that includes effective safeguard to protect the policy from distortion by commercial and vested interest and influence. So one example could be like tobacco or maybe the mining industry. When the investor come in and then, approach some of the people or some of the government officials, they may do some project that could probably increase the income of the country, but on the other side, it may also affect negatively to the people. So sometimes income may be may not be sometimes the expenses which may not be immediate, but long-term expenses could cost more to the people as well as the environment, especially with the mining project. So we have to ensure that there is conflict of interest measure to safeguard to protect the policy from distortion by commercial and vested interest and influence. And to be able to do that, we have to include the policy, social movement, and civil society, and in the development and implementation and monitoring of health in our policy, and then building the health literacy in the population. When the populations are involved, that means communities are well informed about the healthy lifestyle, and also social movement, civil society involved. Sometimes even the government wants to implement those public policy which negatively impact the people. So sometimes they have to stop because community are very health literate. They understand what could influence their health, and they come together and also monitor the health in our policy. So this way, we can promote the health in our policy and make the governments accountable. So joining up government action, we keep saying about it. And then, so if we look at the left side, like economy and employment, we just look at in the video, security or justice, education, early life, agriculture, food, infrastructure, transport, environment, sustainability, housing, community, land, culture, indigenous culture. So all of them are actually interrelationship with their well-being and health. So we just look at from the example. I'm sure you all got it. So I will just go to another slide. And this is also another model that WHO published in 2023. And so health is like multi-causal problem. So we have citizen, NGOs, interest group, academia, private sector on one side. We have ministry, agency at national, provincial, or local level on one side. And we share the society concern together. So so we have to come together and promote the public policy development and implementation, not just problem focus, when the disease start to happen, only by then we start to tackle that. We won't like that. We just want to start the public policy development and implementation in the way of health in all policy so that we can prevent the disease and then promote the health and health equity approach. And this is also this is a new head in all policy model. So you can see that the foundation of the head in all policy is like major foundation, and then all the SEDA come together, and the main 4 pillars are governance, leadership, way of working, and resources. So they should all be thinking about head in all the policy. So this is another model that we can apply when it comes to head in all policy. And way of working and influence they had in our policy. So I understand that we've already started discussion that, okay, how will HASADA go and influence all of those, like, you know, very powerful ministry? So how to do that? Some of the examples are like, we just discussed like some local initiative, which is in Auckland. And like public health physician was discussing about the concern about health. Which is one example in New Zealand. And then one good thing is interministerial and interdepartmental committees. Like we have an example, like when it comes to like develop a policy or guideline, let's say health impact assessment guideline, not just health, not just environment. All the SEDA and government SEDA should come together as committee. This is one way. And the other way is like community consultation, partnership, integrated budget. And then we can do the collaborative process, developing the relationship, co-design, co-delivery, cross-SEDA implementation team, and joint up workforce development. I'm sure there are a lot of like examples from our countries. And data is also important, like before and during the policy statement. For example, health impact assessment. So like health impact assessment of development project. So it's health impact, but like all the other project, how those projects will impact on health. So it includes, for example, we want to do a mining project, and definitely it will affect the environment. And then through the environment or like from other way, how will it affect on health? So we should do like before this project and after this project. And before one project implemented, we should impact how this would affect on health, and then prevent some of the like or trying to mitigate some of the negative impact on health of that policy or project. So that is one way. The other one is HEAT2, which is the health equity assessment tool, which you can download or like apply it, or it's on the WHO website. You can play around with that. And also targeted and policy oriented research and evaluation should be there, so that we will know before and after this policy. And there should be standardized data collection, cross-cutting information and evaluation system. Coming back to the like healthy organ together, like information, we have the data. That's why we can say that before and after the implementation of this policy, maybe before and after the implementation of school nutrition policy, how does it change? How much of impact on the childhood obesity? So this way we can know how this policy is in fact embedding the health. That is one way. And the other one is, of course, legislative framework. So we need to have collection of act, regulation, code of practice that support the policy implementation. Sometimes if we only have the policy, it might not work. We also need to have attached legislative framework. And then after policy is launched, we need to have audit, monitoring, and evaluation, and how this would impact on health. So that's some of the examples that we can work together. So HEAT2 this is like health equity assessment toolkits, and it's a software application that enable interpretation and reporting of health inequality data, and then support the capacity building for integrating this evidence in policy making processes. So we can also try that on the WHO website. It's for free, and you can download it and use your country data, and then you can see the results. So this is a way to do some of if at your own time. And then we can always say that, oh, health in our policy, we need to influence other people. It might be difficult, but we can also start looking. Of course, we can always advocate to other ministry and work together with them. But we can also start with look at adaptation and equity. So this is one project, healthy active learning, Ministry of Health, Ministry of Education and Sport New Zealand come together and promote and improve their healthy eating and physical activity. And they develop share their resources and support to achieve healthy food and water only policy. That means no sugary drink, just water. And then they can work and partner with the regional sport trust, public health unit, government agency to deliver the education and the best education and health outcome for children and young people. We want to make sure that they are physical activity advisor, work with the selected school to develop the environment that encourage play and sports and physical education. So this is one of the local kind of initiative that the ministry come together for the health of the children. This is an example, like, in the high school, soft drinks are water is in. So this is like, you can see from the news. So no more soft drinks in the hut, which is in Wellington, and also like children playing around and also growing the vegetables and decorating the food with the vegetables to promote the healthy food in school. So that's one of the initiative in New Zealand. So we need to always think about in terms of healthy public policy, how will this policy impact health and how will these impact be distributed? So these are the key messages for this healthy public policy. So this is for me. So I have 2:45, so we are doing great with the timing. So I have like group work for you. So you need to pretend that you live in an artificial country. Let's call it Funland. And so there has been an earthquake that has destroyed the main city of this country. And luckily there was a good warning. So everybody was evacuated in time. So everyone is safe in this example. So the city needs to be redesigned and rebuilt, and then new policy are needed because of the earthquake. So the government wants to do things better than before and join up the sector in a health in all policy approach. You and others in your group would present public health, like you are the public health professional, public health and health services professional, and then list the main points that you will make, and why and how health should be included when writing this policy. So I would request you, so it's not like a specific country. So if you all are in one country, same country, any country it can be, or let's call it Funland also. And you will need to discuss, each group will discuss about one policy and then how this policy should consider about health in all policy approach. And then the main points that I want you to discuss is why and how health should be included when writing this policy. You can go up to like 4 points for this, like, what types. But when you come back, one group will need to present 1 point, like very key top one that should not be missed for that policy. So that we will have enough time to present for each and every group. So every group will have 2 minutes for your presentation. So I need to have like the key one, the key policy that should consider. You can go up to like 4 or 5 in your group discussion, and you will have, I think, 30 minutes for discussion, and then coming back and then present, and then we can go into break. So for group 1, you will need to discuss about transport policy and how transport policy should be, how health should be included in writing these transport policy and why it is important. The group 2 is housing policy. The group 3, energy and power policy. Group 4, urban development policy. Group 5, clean air and water. Group 6, disaster preparedness and emergency response policy. So each group will discuss about their assigned policy, and you don't need to discuss about all the policy, just one for each. All good with the group work? Then we can break you into 6 group, and then you will have 30 minutes, and then you can come back, assign one presenter for each group, and you will have 2 minutes for each group to present.
It's great. So Gay's put up all the groups on the chat, PP, so they can see groups 1 to 6 topics, policy areas there. And I think the main thing is to remember why and how health should be included. So
I'll share this slide to the breakout rooms as well.
Thank you, Suzanne. Fantastic. So we'll hit the button and get people into the different groups, if that's okay. Thanks, Gay.
Are you opening the breakout rooms now, Suits? Okay.
Yes.
Thank you.
The group 1 transport policy, whom from group 1 will present, and that you will have 2 minutes to just discuss the main point that you will make about why and how health should be included in the transport policy of this. Over to you, group 1.
Hi, Jeff is here from Group 1. So, in terms of the transport policy, so because this is a disaster, Metro has struck the city.
Dr. Jeffrey, I can't hear you. Could you? I think there's some issue with the audio. Could you increase your volume? Yeah, Jeffrey.
Hi, let me try again. Okay. It's too bad.
Can you try and speak again?
Hi. Hello. Can you hear me?
Yeah.
Yeah, I think that's better.
Okay. Sorry. So
Yep,
in terms
better.
of the transport policy, so because it's a disaster, so an earthquake has struck. So the for the healthcare sector, so some of the things that we wanted to include in the policy is in terms of the thinking of the safety issues. Even with regards to the what do you call this? The rebuilding of the roads, the infrastructure, and then in terms of making sure that we are better prepared for disasters in the future. So in terms of preparedness, we want to make sure that people have proper access to emergency services, including even including the medical ambulance services, and then in terms of thinking about other preparedness measures. And then the other thing that we mentioned is with regard to health promotion activities, having proper pathways, walkways for walking, cycling, access to recreational areas, and then we also wanted to include issues with regards to mental health well-being in the policy. Of course, with all these policies, it is good to have you mentioned before, like the health impact assessment for any projects that's being started for the to rebuilding. I think that's it for 2 minutes. Thank you.
Yeah, thank you very much, Group 1, and then Jeffrey, for presenting on behalf of Group 1. Yeah, it's great. It's said that this city is affected by earthquake, but at the same time, we can rebuild it in a better way. A lot of our countries, especially in our like in Asia, Southeast Asia region, we have very serious traffic because everybody is taking car, and probably we can, as you said, like, there should be proper spaces for walking, cycling. But if it is very far and mega city, we could probably promote the public transport like tube and others, so that, like, we can get better. Not everyone should spend like 1.5 hours in the traffic, which we all face in our city. So that's great, Will, to start. Yeah, thank you very much, Group 1. Now Group 2, over to you for the housing policy. Who will present from the Group 2?
Okay, hello everyone. So I will present our group discussion related to redesigning house after the earthquake. Maybe first we can collaborate with other sectors such as urban design sectors to mapping out where the areas in high risk and low risk zones, mapping the area so the developers and residents know where the building is unsafe and safe. Okay, and then for designing the housing, of course, reconstruction should meet the health and safety standards such as sanitation, ventilation, accessibility, hazard mitigation, and etc. And the resources and support should be targeted to the vulnerable groups, ensuring the access and the fast recovery after the disaster. And the next is maybe encourage the community participations. So housing solution reflect the real needs of the people. Okay.
Yeah,
Maybe anyone
thank-
wants to add the point from group two? Thank you.
I think you covered it well, group 2. Thank you very much. Yeah, safety is important. And now also like looking at the zone, which one is very at high risk, because we've already faced one-time earthquake in this city. That means it can happen again. And that is very good advice to give, and also working together with other setup, which is great. Yeah, the other thing is like probably like a lot of our countries, I mean, even in Mandalay, in Myanmar, we use bricks, which is very like leader or very fit for the building. So like, and then when the earthquake happen, a lot of causality, like a lot of mortality or morbidity happens. So probably we can think about like earthquake safe material, and then the government can think about subsidizing so that everyone can afford, but especially for those people from low socioeconomic situation, they might not be able to afford. So we can think about from equity perspective that the government should subsidize so that they will be safe in the future. Yeah. Great work, group 2. Yeah. Over to group 3, like energy and power policy.
Yes, good morning, everyone. I would like to thank first my group coming from the Myanmar, Vietnam, Malaysia, and the Philippines. So our group is assigned to power and energy, and we would like to share with you that one of the challenges that we got for the power energy, of course, in sustaining and maintaining the operational of the hospitals. So we know that during particularly typhoon devastation, the grid collapse, and of course there are severely damaged power grid, and of course hospital operations halted, and thus leading or forcing to use or improvise life-saving care or devices by our hospital care. Not only to that, there are also challenges of generator, and of course overwhelming facilities, and even our staff are victims. So in the Philippines, what we did for our many challenges, particularly on Typhoon Haiyan or on Yolanda, a devastating Eastern Visayas or the Visayas area, is that there are partnership in terms of policy, sisterhood of other local government units. And because of that, helping each other. No, we have already supplied our energy through generators, but the Philippines did not stop, and we implemented the Republic Act 10121, of which the disaster risk management for health, okay, DRRM for health, was implemented by every hospitals and local government units. So what the LGUs and the hospitals did, the government subsidized for about 30% of the 30% should be coming from the quick response fund, and 70% is pre-disaster preparedness fund. So meaning the hospitals itself, particularly those that are governed by the government, should use the fund in order for them to utilize equipment, particular generators. There are 4 thematic areas of the disaster risk reduction management for health, that is for mitigation, preparedness, response, and recovery. So during the preparedness, we capacitate and include prepositions in order that devastation would come, we are already prepared. And that implementation listen to the challenges of the hospitals, particularly on sustaining the life-saving implementation or functions of the hospital. So we would like to emphasize that even we are victims after that devastations, victim itself, you need to stand up and work again to help others, particularly those who are who are victims of that devastation. And we are still implementing the use of the 30% quick response fund and 70% pre-disaster preparedness that include capacitation and prepositions of materials. I hope this also would be implemented in other areas and utilizing the fund of the government. And aside from the government, of course, non-governmental organizations are there also to help sustain and maintain the function of the hospitals, even at times of disaster. Thank you.
Yeah. Thank you very much, Nino. Thank you very much for sharing your thoughts. Yeah, it's great to prepare because this city already faced like disaster again. So it is prone to disaster. Like everywhere is prone to disaster now with the climate change. But at the same time, during the regular time, like we are rebuilding the city, so we want to make sure that everyone is accessible to power and also affordable one. If the electricity is too expensive, maybe some people may not be able to access the electricity or may not be able to use it properly because they have to save so much because everything, all the equipment, like even for this meeting, everything is depending on the electricity. So, and all the head knowledge, like heating and water supply to the power, like all the houses, it's all are linked. So we want to make sure that everyone is access to electricity at the affordable price also. So like we can think about those kind of policy during the regular time. Of course, during the disaster time, as you mentioned, the government should be very ready and also like have the like specific budget for the disaster preparedness during the disaster time. Thank you very much for sharing that. Now we can go to the like group 4, which is the urban development policy. Group 4, over to you.
Yes, hello everyone. I'm Thành Trần from Vietnam. So I'm in group 4. Actually, we have many the discussion and idea about this. So earthquake are serious and natural event can cause a lot of death, damage the house, and so it's terrible. So for us, for the team, we don't have a much experience for this urban development policy. It's so very huge. But we believe that we maybe with the urban development city, we need to predict the risk and have the comprehensive plan for the city to maybe the construction standards and maybe arrange the storage for emergency. Uh, so for the detail with the roles of the public health management, we would pay attention for the main idea for the policy with urban development. The first maybe the policy for the emergency support. So we maybe we need to establishment of the uh, EOC for the coordination the hospital, health center, and maybe drugs, and we need to know the facility hospital maybe activity after the earthquake, and so we have for the victim for the hospital, and so we have the hotline and receive the call from the victim um, to know. And also second, I think in the policy we need to have uh, the vaccination for the uh, impact area because many the people maybe die, and so the disease maybe have in this earthquake impact by earthquake. And so after the long time, we have the policy with the intersectoral linked to urban development planning. So we need to have the earthquake safety standard for the health facility, the hospital, health center. And so we the second we need to uh, strategic medical storage in the emergency status. We need them, and the third maybe is we um, will have uh, uh, the um, the map for predict the earthquake to to know where we can we can instruct the hospital and inform to the people can know and help prepare. So for is my idea. Thank you.
Yeah, thank you very much, Group 4. Yes, so I think we are like kind of focusing on like preparing the disaster or recovery. And I think we are above the phase because we have to rebuild the whole city. I know it's very sad, but it's also a great opportunity. Previously, our urban design may be very crowded. Then when we are rebuilding the designs, rebuilding everything, we might have like enough spaces for people. And also we might even want to move like some key building like hospital to another places, like depending on how we want to build and to promote the health, like, you know, so we have the opportunity to redesign and rebuild that. So we want to make sure that safe water supply, whether like our water supply is safe before the earthquake, maybe now we can get a better place from a better water supply places. Maybe we have to move the water reservoir from like earthquake prone area to another place. So, or what about the sewage system? Is it good or is it bad? Now it's destroyed, everything was destroyed. So we can also think about a better rebuilding the sewage system, which is also key for the environment. So we can use this example. Of course, we need to be ready for the next disaster, but at the same time, for the like regular period, so we can build it better, like, you know, because we have this opportunity. So thank you very much for Group 4. And what about Group 5? About clean air and water.
Yep, thank you. I think when you mentioned about sewage and water, it flows right into our bit. So I think one of the main points we discussed was having access to clean and safe water. So ensuring that wash conditions are practiced also for all the population. So that would be like safe water, sanitation, hygiene, and in order to do this, we need to make sure that the infrastructures are in place. So it's important to work with the relevant sectors to ensure that, like you said, okay, the safe water diverted, to housing or to where, like, most people need, even to like officers, yeah, not just housing. So that's one of the points we have in terms of access to clean and safe water. The second bit is about ensuring optimal air quality. So there needs to be regular monitoring of our indoor and outdoor air quality, and we need to set threshold for what we think is like poor air quality versus good air quality, and along that line, in terms of reducing emission as a whole. So one of the things we can think of was, for example, reducing emissions from factories, from cars, and then the other bit, possibly, having policies on, say, encouraging the use of electric vehicles, and then try to discourage the use of like petrol or diesel vehicles. So these are the points from our group. Thank you.
Yeah, thank you, Group 5. Yes, these are the things that we are facing, right? Our cities are like, we have a lot of crowded city, and then we are facing like this pollution, like every day. We may or may not measure, and also water supply, that's also very important. Yeah, thank you very much. So we want to make sure that everyone is access to clean and like clean air as well as the water, including the sewage water. Like we have the chance to rebuild the city now. And number 6 is like Group 6. I think a lot of the groups touch upon this point already, which is disaster preparedness and emergency response policy, and like how to
Yes,
include that. Over to you.
yeah, thank you. Our group include participants from Vietnam, Indonesia, Philippines, and Myanmar. So, for the disaster preparedness and response, disasters could be public health emergency. So, our preparedness and response are really important to protect the entire population, especially the most vulnerable, which may include the indigenous people in some regions. So how to include her? The first one is we discussed about to include plans for mass casualty triage and for the disease surveillance to catch outbreaks early, and also for the clear public health communication and early warning system with a multi-channel approach. The second one is about the health facilities. Whenever we build new health facilities like new hospitals or new clinics, we must these facilities must be earthquake proof or located outside the high risk zones like flood area. So, and then must be that these facilities must have their own power and water reserves. This is the second point. And the third point is to include plans for the mental health and psychosocial support, because every disaster causes immense trauma to the survivors and the people. So our plans must include the mental health and psychosocial support for survivors and fast responders for the immediate and long-term condition. Yeah. So our discussions that's all. Yeah.
Yeah, thank you very much, Group 6. Yes, I think a lot of us, we didn't have plan, and then also communication is important. Like here in New Zealand, like whenever there is a cyclone or flood, like they hijacked our like handphone or like mobile devices, and also like send the signal, okay, this is happening, that is happening. So a lot of lives can be saved. I'm sure like if we can have, or we might already have that kind of system, like, you know, either typhoon or earthquake or anything, then, you know, people have enough time to move in the disaster, which is like the first life-saving thing, like mental health, also like triage, everything, because when the disaster happens, we don't know what to do. So, and we can't provide the enough response like timely. So there's a lot of like life were lost. Yeah, thank you very much. I know this is kind of a little bit challenging, just to give you the example, because I also face this kind of situation. Like health, we always stay in health. Like in one of my experience, I need to work for the health impact assessment for the road development project and urban city development project. And there were a lot of engineers were sitting, and I was just looking at them. I don't know what to say. Like, you know, they have a lot of discussion about their project and so on. So I need to learn and then learn about this healthy public policy. And because, for example, in the urban, like, you know, how do they compose their dead body? Like, because all of them can affect how do they dispose their rubbish, what is their water supply, what is their sewage supply. So everything is relating to health. But of course, it was difficult because we used to stay in our own environment in the like healthcare setting or like public healthcare setting. But health is like from like all the one with this healthy public policy, because every policy is important to promote the health. So we need to be the we need to be at our best to advocate for health with other counterpart, which I find it challenging, but I think it's very rewarding too. So from my experience also. Yeah, with that, thank you very much for all your great discussion. And I hand it over to Chris. I think we can have a break now, Chris, right?
I think we can. I think everybody's been working really hard, and just want to thank you for contributing to some great work on this really important underpinning part of how we do public health, which is working collaboratively across all these different sectors. So often the reflex is just to focus on health sector, but actually, as BP's so well pointed out today, and I'm sure we all know it, but we seldom do it, is to think about the determinants of health mainly occurring in other sectors, and that's where we need to have the greatest influence so we can get the biggest impact. So thank you all for that. We're going to have a break now for 20 minutes, and we'll come back after that time. So 20 minutes break, go out, get some sunlight, fresh air, have a glass of water or a cup of tea or coffee. And in Sweden, where I've been recently, they have a break called a fika, F-I-K-A, and they all have a coffee and a cinnamon roll, which sounds like a very good idea to me.
Yes.
But have your local version of whatever that is and come back refreshed, and see you in 20 minutes time. Well, kia ora, welcome back everybody from your fika break. I've put a little link in the chat there. You can find all about that Swedish practice. And it's quite interesting. If you look at the history, apparently coffee was banned, so they made up a code word for it by talking about fika instead of kafi. And so they could have a break. I think the cinnamon buns are optional. But anyway, hopefully you've had a little break and your brain is fresh and you're ready to go for the second half of our session together. And I'm going to hand over now to Monica to lead us through this next session. So kia ora, Monica, thank you.
Thank you, Chris. Kia ora, everyone. I hope you had a nice break. And for the next hour, I will be talking about disease prevention, the theory. And this is the part one. I think the next part, tomorrow, Chris will be talking about immunization. So I made these slides based on what Chris teach previously, but there are also some addition for this lesson. Okay, so I will start with a question for all of us. So let's say if you could meet your younger self, yeah, like 10 years ago, 20 years ago, or back when you were still a teenager or a kid, what health-related advice would you give considering how healthy you are today? So you can look at yourself today. Are you healthy now? And maybe if you could meet your younger self, what would you say to them? Please put 1 or 2 sentences in the chat box. Just simple sentences like, don't eat too much sugar, or to work out more, to have more physical, less junk food, do jogging and hiking. Okay, yeah, so I need to control my diet, but it's capitalized, so I think it's really important. Sleep early. Yeah, I still have problem with that. Also more sleep. Yeah, sometimes we forget about sleep. We only talk about our eating and gym, but yeah, sleep is also important. Not to be picky eater, okay? Oh, because I'm underweight now, okay. So you have to eat more now. Nah, okay. The next one is not eating before sleep. So yeah, I think you two can make a great group. You know, have more fika, more exercise. Okay, yeah. Mine is to reduce drinking Coca-Cola or Cokes. You know, here in this slide, I put some glasses, a picture of some glasses of Cokes. I remember when I was a kid, Cokes and also McDonald's, it's pretty expensive, so only rich kids can afford to buy that. But I don't know what happened. Maybe the economy in my country got better, and then when I was a teenager, Cokes is more affordable to me. So I think I drank 1 bottle every day. Every break I went to my school canteen and I will buy 1 bottle of Coke. And I think most of you also enjoy drinking Cokes or another sugary drink. And I just realized when I was an adult, like maybe I was already 20s, in my 20s, when I realized that what we did when we were teenagers could impact what will on our health when we are like in our 40s or 50s. So I just realized that even now I still haven't know what would this consumption of Coke will bring impact to my future self or 60s. Yeah. Wow, that's pretty scary, isn't it? I mean, I tell people who got like heart disease, it's only because of their lifestyle in the past 2 or 5 years, but it bring back to like decades ago, and it's very scary. So that's why we need to prevent everything, and prevention is a serious topic, but it's also very difficult because you have to trace back to something that happened like decades ago, and it's not simple to do that. So thank you for all your response, and all your response are also related to what I am going to talk about, because when we see a lot of diseases now in this era is related to cardiovascular disease and also cancer. Hypertension, cardiovascular disease, and cancer are one of the highest disease that we face right now. Even though maybe it's also because we ate more processed food and also coke and sugar, and also when we talk about cardiovascular disease, you can see in this picture, in these maps, we have prevalence and also mortality rates and disability related incidents. You can see that in Southeast Asia, there are lots of incidents related to cardiovascular disease, especially in Indonesia, I think. Yeah, it's my country. And also maybe in, Malaysia has a high prevalence but low mortality rate. So that's pretty interesting. But Laos, they have low prevalence but high mortality rates. Yeah, before here in the Philippines, but Philippines are pretty good with the rates. And also we also have another data related to injury. So you can see that there's a lot of cases related to injuries in Southeast Asia. In several countries like Myanmar, Laos, Cambodia, Thailand, there are a lot of incidents related to injury which lead to mortality or disability. And as we can see now that these diseases actually can be prevented. And I found out this quote very interesting because it said that diseases are taxed on pleasures, because we tend to have a sedentary, healthy lifestyle now. I think most of us spending, I don't know how many hours watching social media. Maybe it's becoming a routine that before we sleep we will scroll on Instagram, TikTok, Facebook, or whatever you have, and then maybe before that we eat something that is not healthy, like junk food, and then we say to ourselves like, okay, just one more, just this time, maybe I need to celebrate, but we keep telling that to ourselves, and then we don't realize that we're giving tax on our pleasure, which will be a disease in the future. And I also put these pictures on people using motorcycles. I don't know in your country, but maybe I can say that this also happened in few countries like Indonesia, Vietnam, Philippines, because I see a lot of people are using motorcycles. Maybe because we don't have facilities. Like here in Auckland, I can walk everywhere, like for 2 kilos, 3 kilos, it's okay. But in Indonesia, even only for a few hundred meters, sometimes I'm ashamed to say, but sometimes I use motorcycle, maybe because it's too hot. Maybe it's also because it's not safe for women to walk alone in the street. But then it become our habit. We use the motorcycle just to walk a few hundred meters, and then we have this sedentary lifestyle, and then we don't know why suddenly we get some disease. So it's a kind of pleasure that you can just ride your motorcycle. You don't need to walk, but in the future we have the tax of it. Okay, Indonesians spend an average of 3 hours and 18 minutes on social media. Okay. So that's about my introduction about the disease. And I think most of you have already mastered this. So we're talking about the causes of disease. This is the epidemiological triad of a disease. We see in this model, we see that there's the host or the individual who got the disease, and every disease have the cause, and usually it's the agent, the virus, bacteria, or fungus. I'm sorry, this model was created to analyze communicable disease, but after this we can try to practice it in non-communicable disease, because now we have more NCD compared to the communicable ones. And so there's the host, individual, us who got infected with the disease, and there's the cause. It maybe because the virus, bacteria, fungus, or something else. And also there's the factor, something that might transmit, or a medium that make the virus came to us, a medium that make the bacteria infected us. And also environment, it's maybe the physical chemical components, or also our culture, our history, our socioeconomic. For example, in my hometown, or back in the island of Java in Indonesia, a lot of people now have diabetes, and a lot of people love to consume sugar. But back to the history, Java and Indonesia was colonized by the Dutch, and back to, I think it was like maybe 100 years ago, the Dutch came and they introduced sugar. I don't know the name of the plant. Maybe if one of you know the English name of the plant, because I'm not good. But then they create the farm, they create big industry related to it, and they create a kind of tradition to have like afternoon tea. So that is why a lot of people in Indonesia love to drink tea, especially in Central Java, I think. Central Java and Yogyakarta, my hometown. We love to drink tea with sugar. And it was because the impact that was brought by the colonialism or by the Dutch 100 years ago, because they want to have a big business of sugar. And we didn't know, but then decades after, we found a lot of cases of diabetes, and it is also because we have habits that we need sugar, that we need to add sugar to our tea, even though usually we don't add sugar to our tea before, but it's about the culture and also the history that make the tea becoming a part of the sugar becoming a part of our life. So it's also the environment that also plays part in one of the disease. So can you help me to analyze the other disease? Okay, I have this case of dengue fever. I think a lot of countries in Southeast Asia are still having challenge with dengue. So any of you want to write down in the chat, or maybe open your mic to help me analyze the epidemiological triad of dengue fever? What is the host? What is the vector, the agent, environment? Please, if you want to unmute yourself, or maybe write in the chat, what is the agent of dengue fever? Oh yeah, I just saw the chat. Yeah, the sugar cane. Yeah, that's the name of the sugar plant that was introduced by the Dutch. Okay. Aedes aegypti. Yeah, that's the. I think this picture is Aedes aegypti, right? It's one species of mosquito, and usually Aedes aegypti are more active in the morning, and they have this zebra pattern, and it's very clear. You can see it. yeah, and yeah, usually it's more dangerous to see the mosquito in the morning. I know this because I got infected with with dengue like for so many times when I was a kid, and the doctor keeps telling me, be careful if you see the mosquito in the morning because it might be Aedes aegypti. Okay. Okay, Aedes aegypti, thank you. And the factor, oh, sorry. Yeah, the factor, the mosquito, the agent is the dengue virus, and the Aedes aegypti, the mosquito, it bring the dengue virus to the host. And what about the environment? Anyone has? Stagnant water. Yeah. The unique thing about the Aedes aegypti. Oh, sorry, Chris. Do you want to add something?
No, I was just going to say someone Hannes put in crowded cities and poor waste management.
Yeah, poor waste management. Oh, I don't know about this, but all I know about the Aedes aegypti mosquito, it's also they also live in clean environment, but as long as there are stagnant water, they can live there. Yeah, so maybe Chris. The streets.
Oh, yes,
sure, yeah.
very good. Tropical climate, rainfall, poor waste.
Yeah. Okay. Whoa, very good. Climate change. Yeah, I think so. I think that the hotter the place, then there will be more mosquito because I never saw any mosquito here in Auckland.
No, but with global climate change, it's possible that it could be sufficient to enable these mosquitoes to breed here. But we have had cases imported here in Auckland from overseas, but they don't transmit because the vector is not present.
Yeah. So yeah, that's great. Some people mentioning the climate change.
Yeah, that's
And
right.
then it's sanitation, clean and still water. Then yep, you're right. Pohnpei, clean and still water. Female Aedes recording album. Okay, right. Okay, thank you. Great, everyone. Everyone's got A+. And then the next one. What about this? Hypertension. So we try to adapt this triad into NCD. I think it's a bit more complicated, but I know you can do it. So, is there anyone who wants to open the mic to unmute themselves and then analyze this one? Or you can also put it in the chat. Oh, yeah. I like it what Chris said about the risk of social isolation. More time with other people is a protective factor for health. But to be noted that more time with other people in real life, because I think because there's a lot of young people these days spend more time with other people, but it's in social media or using the digital life.
Can I just suggest, Monica, maybe one of the agents for hypertension could be salt intake, dietary salt intake? Just a thought.
Yeah. The salt
See what
intake
people think.
is the agent, one of the agent.
Mm-hmm.
So Chris has give us one of the key.
Here we go.
Thank you, Yuli. High salt intake, obesity, smoking, lack of physical activity, excessive. Whoa, okay.
Wow.
Very complete. And what about the factor? I think the most tricky one is the factor, right? Hypertension arises from house, behavior, house, age, genetic, lifestyle, elevated blood pressure itself. Is this okay? Salt intakes. Okay, the environment is poor access to healthcare. Okay, that's a great input. Yeah, when people don't have access to healthcare, maybe it also make the hypertension it's more unmanageable. Okay. What about the factor? I think I don't see anyone talking about the factor, right? Poor diet. Okay, Jeffrin mentioned poor diet,
Maybe
but
for
I
Monica, maybe it's for the behavior sector. We can consider about the unhealthy diets, smoking, or the alcohol use.
so the unhealthy diets and smoking. So the behavior. So the factor is the behavior, right, Jennifer? Is that what you mean? Okay,
Yeah,
so the agent is the salt intake, but the factor is the what is it? The behavior. Okay. Thank you. Does anybody have other opinion? Commercial companies that market. Oh, okay, that's great. I was about to say the same thing. So the factor is something that make the agent come to the host. So yeah. Oh, okay. Huang Nguyen, you want to add? Oh, no. Okay. Yeah, so factor is something that make the agent come to the host or the host can meet the agent. So I think some of it is like the commercial companies. So there's a lot of companies, or maybe it's not always about the companies. It's about like movies. Like maybe you watch some movies and people eating like the noodles, like Indomie, like in Indonesia we have Indomie or other noodles, and they're putting more salt, or they just ate something that it's very salty. It's also become the factor that make the agent, the salt intake come to you, because we already know that salt intake will make us at more risk with hypertension, but the factor is something that make it closer. So I agree with Chris. It's like commercial companies or movies or anything else that like stimulating your vision, so you want to consume more salt. Okay. Any factors that promote exposure? Yeah, thank you, Kay Cinco. You're right. There's another you need to eat salt to prevent iodine. Okay. Yeah. It's a kind of dilemma in Southeast Asian country, because we need to eat salt to prevent iodine deficiency, but then it also make us having higher risk of hypertension. Okay. Peer influence also. Yeah, so maybe it's your friends who is the factor, or your family. Okay. Okay, thank you. Maybe the smell of food in my apartment. If I open my window, I can smell the smell of fried chicken, and it's very, I really love the smell, but it's very not healthy. Okay, thank you everyone. Let's continue. So yeah, I think by analyzing this, we can get a whole illustration on what we should do before we prevent something. Every time you have to prevent a disease, you have to analyze, and you should know that there are a lot of things related to disease prevention, and it's not that easy. So that's why it's not that easy for us to just say to someone, just stop smoking. It's not that simple, because there's a lot of things that makes people want to smoke, and it's not only a single thing, but a complex environment, and also factor and agents. Okay, so talking about prevention, we start from the definition from WHO. It's specific or population-based and individual-based intervention for primary and secondary or early detection of prevention, aiming to minimize the burden of diseases and associated risk factor. So I believe that all of you already know what primary and secondary intervention is. And in WHO definition, it focuses on primary and secondary intervention, prevention. So primary prevention is something that we do to avoid a manifestation of disease before the disease happen. So I don't have any problem with hypertension, but I choose to not eating too much salty food. So it's what I do before the disease happen. And the secondary prevention is early detection to improve the chances of positive health outcomes after the disease happens. Maybe because I'm a psychologist, I have more example related to mental health issue. For example, if you see someone who is histrionic, so they have like panic attack, something like that. So the disease or the attack is already happened. So secondary prevention is when what we do as the first aid are to prevent this panic attack become longer. And usually as a psychologist, we will do some first aid psychological things like deep breathing and mindfulness, something like that. So WHO definition focus on primary and secondary prevention, but we need to know that prevention are not only about primary and secondary, but it's also about, we also have primordial prevention and also tertiary prevention. Although we need to focus on the primary and secondary one, we also need to consider the primordial and tertiary prevention. The primordial prevention is about establishing and maintaining conditions that minimize hazard to health. And usually it's a bit more difficult because we not only focus on the disease itself, but we aim to the broader area, maybe the environment, maybe the culture, the social life, and also the policy. I think it's also related to primordial prevention. Oh, sorry. And also the tertiary prevention. The aim is to reduce number or impacts of complications. So, for example, if somebody is already diagnosed with bipolar disorder or depression, then, or maybe autism, for example, because I think there are no more cases of autism in the few years. So we know that it is not curable, but we can do something so we can maintain the function of the person who got autism or another mental health issue. I remember I worked for a few years as a behavior therapist before, and I remember we have this case of a 7-year-old with severe autism and hyperactivity. And every session, I think I gave like 2 or 3 session behavior therapy, but it's always the same thing that I do, the same activity, the same toy. There's nothing that we can do to cure it, but we're doing this tertiary prevention so that their condition of this kid is not getting any worse. I remember after like I did that for like 2 until 3 years, just doing the same thing 2 until 3 times a week. It's kind of boring, and I came to the point that I was asking my friend, why are we doing this? I mean, let's just stop it. We didn't make any progress with this. But then after that, I saw we have another new kid, another new patient with autism, and we knew that this kid came from remote area and they didn't receive any treatment at all, and the condition are much worse. So this is what we did during the tertiary prevention, just to make sure that they can function. We cannot cure it, but at least they can still function. Okay. Chris, do you have anything to add?
No, I think that's really interesting.
Okay.
Yeah, and a good example from somewhere in the mental health space rather than, cardiovascular, etc. But I'll pop up on the chat just some other examples of tertiary prevention that people might like to think about. It's sort of about keeping people functioning, as you said, rehabilitation, trying to mitigate the kind of maybe slow down the natural history of regression, so people can have can flourish even if they have some medical condition that's existing, to reduce the impacts of or reduce the likelihood of having complications.
Yeah.
There's some examples.
Yeah, thank you, Chris. Yeah, related to this is I also remember I have a neighbor back in Indonesia and he had stroke, but I think he cannot go back to his previous healthy condition, but he need to underwent some rehabilitation just to keep him more functioning so he can go to work. Yeah. Okay, thank you. So this is one of the example that I have related to primordial prevention and primary, secondary, and tertiary prevention here in New Zealand. Is related to preventing maternal morbidity, and I think one of the great thing about New Zealand is that we have clean air, and also we have access to pedestrian, so we can walk everywhere, and mental health support for everyone, and it's the primordial prevention. So if when someone is pregnant, is preparing to have a baby, they can keep their healthy lifestyle because the government already facilitate people and it's not only useful for people who are pregnant, but it's useful for everyone, if we can go outside and just take a walk, it's really healthy for us. So the primary prevention in maternal morbidity here in New Zealand is related to clean air and mental health support for everyone. And the primary prevention is that to prevent someone to have any case of complication is that there are routine checks, there are blood tests, there are ultrasound education from midwives and other service from the lead maternity care or the LMC for pregnant women. So and also they also have this test. I think the NIPT test also available not only in New Zealand but also in another country, including in Southeast Asian countries. So we can detect if there is something related to the baby or also the mother. And then the secondary prevention is like the early treatment of monitoring of diabetes, for example, or referral to another specialist based on condition assessed during the pregnancy. So once we know something, we need to do a quick action to prevent something bad to happen. And then, for example, the woman experience complication, and maybe they have to endure a long-term effect related to this. But also in New Zealand, we already have a lot of resources for that, like postpartum physiotherapists or other postpartum service here in New Zealand, because I also experienced this whole pregnancy process in New Zealand, and I really appreciate that the midwives came to my house until I think it was 6 weeks, and then they also assess whether we are in a good condition or not. If we are not in a good condition, then they can continue the home visit. But because we were in a good condition, so they asked our family to go to the clinic by ourselves. Even though we don't have car, but we can move around. So they suggest us to come to the clinic. But if we have something else, like we have a certain condition that makes us unable to go to the clinic, or there are certain condition in the baby or the mother, then the postpartum service are going to going to receive the postpartum service for more than 6 weeks. So that's also the tertiary prevention to prevent the kids or the mother to have more effect from the complication. Oh, okay. Now, primary, secondary, and tertiary prevention are not the same as primary, secondary, and tertiary levels of healthcare services. Okay. Okay. Thank you, Chris. And then, wait. Okay, now we are talking about the, yeah. Okay. Now we are talking about the risk factors. So as you can see here, this the data about risk factor related to various diseases, and the data is from 2021. And particulate matter pollution is the highest risk factor that we have worldwide. And I think it's also a serious concern in several Southeast Asian countries, like in Indonesia. I think I also heard in Vietnam, Bangkok, we have some issues related to air pollution. And the other interesting thing is that you can see here in the year of 2000, high systolic blood pressure ranked number 4 as the risk factor, but now it's in the number 2. So NCD are a serious thing to be concerned. And also smoking moving from number 5 to number 3. But other concern related to environmental and occupational, like for example, unsafe water source and unsafe sanitation is, maybe we can say it's no longer a priority for us, because I think in the last 20 years, maybe the government can tackle this issue related to water source and sanitation, but our lifestyle makes us are more at risk with high systolic blood pressure and also plasma glucose and cholesterol. I think, yeah, it moves forward from number 8 and 9 to number 5 and 6 and 7 and body mass index. So it's most of it are related to our lifestyle. And if we can see in Southeast Asia and also in New Zealand, you can see in this graphics. So blue means everything is going right. Yeah, the darker the blue, then the better it is. But yellow to red means everything is not going right. It's related to the disability rate of child and maternal nutrition. And we can see that over 2 decades, countries in South Asia have practiced a lot of strategies to help people and make progress related to child and maternal nutrition. As you can see, it was all red or mostly red in Southeast Asia in the year of 2000, but recently or in 2021, it is no longer, yeah, it's still a threat for us, but it is much better than it was in 2000. However, if we talk about air pollution, I don't know whether I can believe this data or not, but in this data, it said that we are already in better condition related to air pollution, but we have to note that this data is in 2021. I think I remember it was like 2022 or 20 and 2023 that there was some cases of air pollution in some countries like Indonesia and other countries. So I think air pollution is still a concern in Southeast Asia. And then we need to see high systolic blood pressure. We can see that in Southeast Asia, as a risk factor, this high systolic blood pressure, that we didn't make any significant changes related to this. But in Australia and New Zealand, you can see that the darker the blue, it means that the better the condition. So there's slightly a change, and it's getting to get better in Australia and New Zealand. But in Southeast Asia, I think Thailand did a good job, and Vietnam also, but most countries, we're still having some problem with the blood pressure. Okay, and how do we tackle this? How do we tackle all of this disease? There's two strategies related to prevention. The first one is the high-risk strategy of prevention, and the second one is the population strategy of prevention. As you can guess, the high-risk strategy means that we aim to give the programs, or we aim to make strategies to people who are at high risk. So like people with hypertension, we ask them to reduce the salt. But in population strategies, we don't only target the high-risk people, but we target all the people. So we don't only talk about specific group of people, but we're talking about the whole population. The good thing about the high-risk strategy is that if people is at high risk, they might have a higher awareness, so they might likely to comply with whatever strategies that are given to them. And it is also cost effective, and also it's concentrated, but maybe it sometimes does not seek to alter to the underlying causes. We know people are on this group, but we only aim for the group, but not for the underlying causes of what makes this group are on high risk. On the other hand, the population strategy is targeted to all of us, like just how we have to use seatbelt, or how we have to use helmet, or how all of us have to underwent some series of immunization back when we were a kid. And also, it is also related to primordial intervention like clean water supply and sanitation. And it sometimes remove underlying cause, but on the other hand, maybe the motivation for people to comply with this strategy is low because we don't see the risk. We don't know what is the benefit if I don't use, for example, if I don't use seatbelt, what if the risk? So we don't know about the risk, so sometimes people don't comply with this strategy. So I have an example from New Zealand. There's some cases of SIDS, sudden infant death syndrome, or sudden unexpected death in infancy. And here in New Zealand, I don't know whether this issue is an issue in your country, because what I read is a lot of countries in Asia have low rates of SIDS or SUDI, but here in New Zealand and in a lot of Western countries, there's a lot of cases related to SIDS. And one of the factors that make that increase the rate of SIDS is when people pet share, when parents do pet sharing with their babies. So we found out, so in New Zealand, there are some groups that are in high risk of SIDS, including people from the ethnicity of Maori. However, bed sharing is sometimes also a culture that we practice. So maybe it's not a Western practice, but in Asia, I think a lot of us maybe, well, I didn't bed share with my parents, but I think a lot of people bed sharing with their parents. The parents and children used to share the same bed, and even not only with one baby, but like the whole family, they sleep in the same bed. However, in the group of Maori people, they share the same bed, but there are also a high rates of SIDS. And in New Zealand, most families are encouraged to practice safe sleeping practice, in which infants should sleep in different beds from parents, but in the same room. So different bed mean they are put in a bassinet just next to bassinet or crib next to parents' bed, but not in the same bed, because it might dangerous, because it might increase the risk of suffocation. However, for Maori people, it is difficult to practice that. So there is this solution or this prevention strategy, which is the pepi pot and the wahakura. Certain families here in New Zealand are eligible to receive this pepi pot or wahakura. It's a small bed. It's very small. You can see in this picture. It's only a small plastic box like that, and people can put it on their bed. But it also creates some safe space for baby and for parents, so they can share the bed, but the risk of SIDS will decrease. And in New Zealand, we have this wahakura and pipi pot, but you cannot just buy it everywhere. It's not available on the stores. You have to talk to your midwife, and they will assess whether you need pepi pot or wahakura. If you are eligible for that, then they will provide you with that. So pepi pot and wahakura is given to families who choose to bed sharing, but most families are encouraged not to bed sharing. And wahakura is also developed culturally, because it is related to the culture of Maori, and then there are community of wahakura weavers. So what do you think about this prevention? Which prevention strategy is being used here? Is it the high-risk strategy or the population strategy? Can you put your answers in the population strategy? Okay, in the chat box. In our home, we used to sleep the same bed with all the family members. Population strategy, is it? Higher strategy, and they will be assessed first. Higher strategy. Yes, yeah, you're right. Yeah, so there's assessment. It's not available for everyone. If it's population strategy, then it will be available for everyone. But as you can see, I know that here in the first paragraph, most families are encouraged to practice safe sleeping practice, in which you are not allowed to sleep in the same bed with your baby. But some families, certain populations, certain groups, they can share, but they will be provided with this pepi pot or wahakura. So this is the high-risk strategy for people from certain population to allow them to practice bed sharing, but in a more safe way, so it can prevent the rate of SIDS. And I think it's not only a good example of high-risk strategy, but it's also a good example of how we can create a solution when the science and culture are not in the same direction. Sometimes it also happen in Asian country, right? So maybe the science said this, but also we have that culture, that tradition, and then people choose to sometimes we think of it as a black and white. When you choose the culture, then you ignore the science, or the other way around, you choose the science and you forget about the culture. But wahakura is a great example that we can still keep our tradition of bed sharing, but we can also use science to prevent any kind of disease. Okay, so it's the high-risk strategy. Thank you. Wait, and then, so then sometimes we thought that, okay, high-risk strategy are more effective. But then maybe we need to ask ourselves, so what is population strategy is used for? So I think Chris has mentioned on the chat, there's a good article from Rose. I also have uploaded the article in the Canvas, so you can also download it from Canvas. So this one is called the prevention paradox. It is a condition with when majority of people with a certain disease came from low-risk population. And for this case, then the population strategy of prevention is needed. So for example, let's say we have a group of people with like Down syndrome. We know like that one of the risks of Down syndrome is when a baby is born to a mother who is already 35 or older. So the high-risk population, can you see that I'm making a mark here? The high-risk population are children who are born from a mother who are 35 years old or older. And we can see here that I put some different colors on this. The people who are black people is people without the disease, and the orange one are people with disease from high-risk group. So in this high-risk population, there are more people with the disease. There are more children who are born as Down syndrome, with Down syndrome. I'm not talking about the exact prevalence because I didn't check the exact prevalence, but this is just to help us understand the theory. And then there are also another group of people from low-risk population with all, and they are, some of them also have the disease, which is Down syndrome, and I make them as the red ones here. So there are some small portion of people from the low-risk population who are with the Down syndrome. And when you try to combine the red ones and the orange one, you can see here that here in this, I make circle here. Okay. You can see that there are more people from low-risk population compared to people from high-risk population. It is because the population, the overall population from high-risk population are smaller. We know that there are more people who gave birth before they are 35 compared to people who gave birth after they are 35. So it is small, but it is small if we compare it with the other children. But in their own population, it is the percentage is high. So this is why we still need the population strategy, because most of the cases are from low-risk population. And also when I made these slides, I also remember that a lot of people usually make claims, and it's kind of biased. Let's say we say, let's say we have a family member who already 35 or more, and we told them that, okay, be careful, because if you are having babies after 35, maybe you need to test during on your second trimester, because there is high risk of Down syndrome. And then maybe the other person, maybe other people will say, no way. I know a lot of people with Down syndrome, or maybe I'm a teacher in a special needs school, and I teach a lot of children with Down syndrome, and most of their mothers are still young. not 35 or more, because we only look at these people with disease. So it kind of makes kind of bias for everyone to understand this situation. But it is the reality here that population strategy is still needed, because most of the case also came from the low-risk population. And also, wait, I need to stop the, okay. And also, when we use the population strategy, we shift, we shift the normal curve, not only aiming at the high-risk people, but also we aim to shift the overall population, so it prevent more people, it prevent more groups from having the disease. So this is why we still need the population strategies. We need the high-risk strategies, but we also still need to practice the population strategies, because if we already aim at the high-risk group, then we only aim for the group in this red area. But if we aim to the population, then we can shift the curve and we can help everyone, not only the high-risk group. Okay, so this is about the prevention paradox, and you can read the article from Jeffrey Rhodes. Okay. Yeah, paradox, a situation or statement that seem impossible or is difficult to understand because it contain two opposite facts. Yeah, it's difficult to understand. It also sometimes create bias, so it's difficult, but it's also unique. Sometimes it's simple, but it's also difficult. Yeah, it's the paradox. Okay, so it's about the paradox, and I'm going to continue. I think I'm running out of time here. Okay, I will be talking about the screening, but I think I'm running out of time, so I think I will jump into the example.
Yeah.
Yeah, okay. So we have some example of screening in New Zealand, and one of the great example about screening in New Zealand is a self-test pap smear, in which you can do pap smear by yourself. So there's a self-test cervical screening, because I think for some people, I think we have notes in this that a screening should be acceptable to population, and for some people it's uncomfortable to let other people do the cervical screening to themselves. So here in New Zealand, you can just do it on your own and swab yourself, and then bring the kit to the lab, and then you will get the result. So there's no nervous thing. And also, I think we still have some time to watch the video. There's this bowel cancer screening for the Pacifica community. I will stop sharing, and then I will share the video. Share. Okay. Can you see it?
Does it have a sound, Monica?
Sorry. So
just maybe.
Yeah, just click share sound before you share.
Sorry.
Yeah.
Sorry. Okay. Oh, wait. Share. Share sound, right? Share computer sound, right? Wait.
Happy birthday, mate. It's your bowel screening test.
Cheering on fellow Pacific Islanders to go and get tested. You've got this is the slogan highlighting the importance of a new bowel screening campaign here in Aotearoa.
You can poo it!
A campaign aiming at taking the stigma out of a test that can save lives.
Begin the conversation about getting your screening for bowel cancer early. And as the government, we've said we begin at 50 for Māori and Pacifica. Too many of our people are dying. They are preventable deaths. And so we want to be able to save lives by helping people understand some uncomfortable issues about how the screening is done.
Right now, if you're 60 to 74 years old, you're eligible for free bowel screening tests. But as of July next year, the testing age will drop to 50 for Māori and Pacific. A high proportion of bowel cancer occurs in Māori and Pacific peoples before they reach 60, at approximately 21%, compared to 10% for non-Māori and non-Pacific peoples.
If you're the one Pacific person that gets bowel cancer, it's incredibly important for you and your family. And I think every health measure that can save a life is worth it. And the problem is, when you're doing a screening test, you don't know if it's going to be you as the one that's got their life saved.
Bowel cancer survivor Laloma Afiaki says the campaign to get tested is a positive step forward.
It's affecting me emotionally towards the end because I lost my wife to bowel cancer. If only we knew then what bowel cancer can do to you.
The first step to getting tested is as easy as going to your GP.
If you're a Māori and Pacific person and you want to do the test, you can do it. There's a system whereby your general practitioner can just arrange for the test to be sent to you right now. Or your community provider that you're linking in with in some of these community events, they can just arrange for the test to be sent to you.
The campaign today is about making bowel screening easy with free kits you can test yourself with at home, and the Minister is leading the way.
I, like everybody, was feeling uncomfortable with it. You've got to read the instructions, take your time, close that door, but it's easy. And once you've done it the first time, I just know it'll become easier every year to do it. And it is about saving lives. It's safe, it's free, it's accessible, and you can do the test in your own home.
Of course, leading a healthier lifestyle can help prevent cancer.
Like a lot of cancers, the key to this is healthy eating and healthy living, and appropriate degree of physical activity, appropriate weight, all those things that and don't smoke, all the things that we don't like to hear, but they're actually the things that are good for us and will actually save our lives and prevent not just bowel cancer, but also other cancers.
Okay, that's about the bowel screening. And yeah, I
We've got
think
about 2 minutes left, Monica.
yeah, I only have 2 minutes left. Yeah, by the way, the one thing that I really like from the video is like the jargon. You can put it like that. So yeah, it's kind of encourage people to do the screening. So I think my time is up. So, but I already share my slides. But maybe we can continue to discuss in the discussion in Canvas if you want. I have some question for you. What this is now currently in your country, and then you can apply the epidemiological triad, and then what do you think should you use high risk or population strategy, and identify the screening tool that that needed to be used in your country. I think that's all from me, Chris. Apologize for the time I
No,
talk.
not at all.
Yeah,
No,
I
it was
thought I will
good.
be finished by like half an hour, but then suddenly it's already 50 minutes. So thank you, everyone.
Thank you, Monica, and that was great. I think there were some great examples from different things that we often talk about. So drawing on your background in psychology and so forth was really interesting. Plus those other examples, I think, just helped to drill down and embed the models and so forth. And there's some great chat in response about the different things that are going on in different countries, for example, with cervical cancer screening. And, we know about all these screening programs, breast screening, bowel screening, cervical cancer screening. These are all great programs, but I've put in a reading for you and a link to it, which is a kind of a caution about needing to make sure that the benefits of screening programs outweigh the harms, because all screening programs cause harm. Only really good screening programs have an overall benefit. So that, just think about those words. All screening programs cause harm. Only really good screening programs. So if they're not poorly designed, there's no quality control. They can actually make, because most people who have a screening program might be given false reassurance if they have a test that says it's negative, but they actually have the disease, or they might be given a whole lot of fear if they have a test which tells them they're positive, but actually they don't have the disease. So it's all about the quality and the testing and getting that right in communication. So that's if you're going to go for a big program. Anyway, there's lots of reading about it. So the two readings I'd recommend are the ones I just popped up, the Jeffrey Rose, Sick and Healthy Populations. That's all about the two strategies, the high risk and the population strategy Monica talked about, and then the screening programs one. And that's secondary prevention, screening, primary prevention, finding risk factors and trying to prevent them from having their impact downstream. So thank you very much for your attention, for your active contribution on the chat and in the small group work. Love it. We're going to close with a karakia now. We'll see you all same time, same channel tomorrow. And we're going to talk about, tomorrow, we've got immunization and we've got health promotion models. Is that right? Yep. Fantastic. Okay. Brilliant. So, and Gay has just double checked all the readings and presentations, because some of you had some difficulties opening them up, and they've all been checked and they all seem to be working well. So sorry about the technical issues, but we hope it is all fixed now. Okay, let's close with a karakia. This is a karakia whakamutunga, a kia tau te rangamaria ki runga a ia tātou, kia ote pai, a tātou mahi, haere pai, hoki pai, noho pai I ngā wā katoa. May peace be upon us. May our work be completed well. May we go well and tomorrow return well and always be well. Ka kite anō. Thank you so much. See you tomorrow.
Everyone, thanks, Chris.
Thank you
Thank you, Monica.
See you
Thank
tomorrow.
you, Chris. Thank you, everyone.
Thank you,
See you
Chris.
tomorrow.
Thank you,
See you
Monica.
tomorrow.
Thank you.
Thanks, Chris, Monica,
Thank you
PP,
very much,
Suzanne,
Gay,
Louise.
Suzanne, and everybody else who took part today. PP.